about this topic, I really thought about what my patient with a newly diagnosed small cell lung cancer would like to know. And, as much, as less as they want, or as much more as they want, you should always be ready. So this is my entire stack, I would say right now. But what I want to talk about is our just our current insights and future directions in small cell lung cancer. There is a lot that's going on, and that's why I had to restrict myself when I was making the slides. So small cell is a really big fight in the clinic. It is only consists of 15% of lung cancer, but boy, is it aggressive. Majority of patients are diagnosed with stage 4 disease. With all the improvements so far, we've been able to improve survival beyond 10%, but it is still at just 12% at 5 years. The issue is not that it's not responsive to therapy, it's actually highly responsive, but then it recurs. And when it recurs, subsequent lines of therapy have historically have had limited efficacy. And small cell lung cancer is also staged a little bit differently than non-small cell lung cancer. So since I'm going to be using those words in my presentation today, just broadly, small cell lung cancer is defined as limited if it is in an area of the chest where the radiation oncologist can say that I can target this with radiation. And it's called extensive if the radiation oncologist said it's just too much, I can't target it with radiation, or if it's spread out of the lung. So there are two big stages of small cell lung cancer: limited stage, which is considered curable, and extensive stage, which at this point is considered incurable. So I would like to start with where we are currently with treatment and just kind of focus on the newer treatments that have been approved in this field over the last few years. So really, as it was mentioned before, I didn't even want to focus before 2019, because really what we were doing before 2019 was giving everybody chemotherapy and more chemotherapy and more chemotherapy. I think the bar really shifted in this field, or moved a little bit, with the approval of a type of treatment called immunotherapy with these drugs called atezolizumab or durvalumab, which were given for patients who developed extensive stage disease as their first treatment. And then we saw a bit of a gap. And then we saw approval of immunotherapy in limited stage disease very recently, and also an approval of a new drug called tarlatamab, which I'm going to focus my attention on a little bit here. And we also had approval of a chemotherapy in 2020 called lurbinectedin, which targets the DNA directly, and also gave us a option for patients who have who progressed on their first type of treatment for small cell lung cancer. So focusing on immunotherapy, this is really the therapy that moved the needle a little bit for small cell lung cancer. What is immunotherapy? What is immunocheckpoint inhibition? So we all have these soldier cells in our body called T cells, and these soldier cells are kept in control by our body through these brakes known as PD-1, PD-L1s. And these brakes are supposed to prevent your soldier cells from attacking your own body. But this soldier cell also attacks cancer. This is our body's ability to protect ourselves from abnormal cells, which can become cancer every day in our body. And what very aggressive tumors do is that they outsmart the T cells, and they do not let them attack them. So what does immunotherapy do? Immunotherapy just cuts off that brake. It's called as anti-PD-1 or anti-PD-L1. And what it's doing is it's like literally cutting that brake. So now your soldier T cell, your own body's immunity, can fight the cancer. And this, immunotherapy is really just this one big thing that has revolutionized the treatment of cancer in general, because we are harnessing our own immune system. And the same thing happened for small cell lung cancer. In 2019 and 2020, we saw approvals of two immune checkpoint inhibitors, atezolizumab and durvalumab. And basically what these figures show is that for the IM Power 133 trial, patients who got atezolizumab, which is this blue line on the top, did better than patients who did not get atezolizumab in addition to chemotherapy as their first treatment for small cell lung cancer. And on the other side is the Caspian trial, which showed a similar benefit with durvalumab. But in reality, the absolute benefit of adding immunotherapy was about 2 months. But what we saw was what we had not seen in small cell before is the flattening of the curve means that when patients had a response, they had a higher chance of continuing that response for a longer time, which is what we call as durability, which is what we had not seen in small cell before. Whatever works in an advanced stage disease is always works in a limited stage setting as well. And this is what we saw with the Adriatic study, in which similarly durvalumab, the same immunotherapy, was introduced for patients who completed their primary treatment for limited stage small cell lung cancer, which is often a combination of chemotherapy and radiation. And then they were given either immunotherapy or placebo. And what they observed is that patients who received immunotherapy after completing a curative intent treatment for limited stage small cell lung cancer did better than people who did not. So this kind of has solidified immunotherapy in the landscape of small cell lung cancer. It works for some patients, and when it works, it gives them a chance of stay with the cancer being under control for a longer time. But it is not perfect. Immune checkpoint inhibitor therapy is helpful, but it is not enough. Immunotherapy helps some people by boosting their immune system to fight the cancer. But if you look at the absolute numbers in a big population, it's only a modest improvement. And most patients still see the cancer return. The frustrating thing really with small cell lung cancer is that small cell lung cancer can hide from the immune system. And this makes it harder for the immunotherapy to work effectively. We have certain receptors on our cells, or cancers can have certain receptors on our cells that make them more receptive to immunotherapy, and small cell just knows how to hide it. And there is really at this point no clear way to know who will benefit and who will not. And that's why currently we give this treatment to all our patients who come into our clinic and have never received treatment for small cell lung cancer for advanced stage disease. But we are constantly looking for what we call as biomarkers for immunotherapy, so it can really be used in a more targeted fashion. Lurbinectedin was another promising drug, which was also approved in 2020. And lurbinectedin, in comparison to what I discussed before, this is actually a chemotherapy. Lurbinectedin works by targeting the cancer cell's DNA, and it stops the DNA from making proteins that they need to survive. And this basically leads to cancer death. It also works by reducing the inflammation in area around the tumor, which makes the tumor more effective. And the approval of lurbinectedin, we used to give lurbinectedin as our first treatment after the first line of treatment stops working. This was our second option to go to. And this was based on a study of 105 patients with small cell lung cancer who had stopped responding to the first type of treatment, where it showed a response rate of upwards of 30%. And the FDA gave it an accelerated approval, and a confirmatory study of this is currently ongoing. So this is still something that we use for patients who have progressed on one or more treatments for small cell lung cancer. But this too has, it has definitely covered some need, but there's still left a lot of unmet need in small cell lung cancer. Lurbinectedin, like immune checkpoint inhibition, only provides modest benefits. It can shrink tumors in some patients, but majority of patients, only 35% response rate, but doesn't work for all people. Especially the patients that it doesn't work in are the set of patients known as platinum refractory. These are a particular set of small cell patients who we gave them their first treatment, and they had a very, very short response, means that they didn't have a long response to the first treatment we gave them. And this is the hardest set of small cell patients to treat because of the aggressiveness of the disease. And particularly in this set of patients who actually need response the most, lurbinectedin has a poor response rate of close to 20%. Also, responses with lurbinectedin are short-term. Um, there is again no way to predict who will respond, and side effects can be difficult to manage. This is a chemotherapy, so it does cause side effects including fatigue, low blood count, predisposing you to risk of infections. And these side effects are challenging for patients who are already weakened by the cancer, especially if the treatment is given over a longer period of time. That brings us to our most recent approval in small cell lung cancer that has moved the bar quite a bit. And this is a drug called talatamab. Now, what is talatamab? I like to refer to talatamab as a targeted immunotherapy. So, what it is it's an engineered antibody. Antibody is a drug that attaches like a magnet to a cell that it recognizes. And rather than being a magnet to just one cell, which is what most of the antibodies do in our body, this is an engineered magnet that attaches to two cells at the same time. So it has an ability to bring two things together that would have not come together before. So what in this scenario, it brings the small cell, it attaches to a receptor on the small cell called DLL3, and it brings it close to the soldier cell, which is the T cell. So it basically, the small cell which was hiding from the immune cell cannot hide anymore, is because there's a magnet that is attracting both cells to come together. And by doing this, it lets your own immune system fight the small cell, which the immunotherapy was having a tough time fighting before. So definitely, a great concept behind this. DLL3, the part of small cell that it targets, is highly expressed in small cell tumors. 70 to 80% of small cells express that target which it attaches to. So why do I think that this is a revolutionary treatment in small cell lung cancer? This has really helped me give my patients hope, because this is a treatment that is given for patients who progress on the first line of treatment, which is right now chemotherapy plus immunotherapy. And historically, the responses that I was used to be quoting in patients was, yeah, maybe 30%. Yes, some patients can have 40%, but there was no durability of response. The response didn't last for a long time. But in this situation, it has an impressive response rate. 40% is just the response rate, but it actually controls the disease in 70% of the patients. And often control of the cancer is a very important thing to achieve in small cell when it's really growing rapidly and spreading to other places. The responses that are achieved are durable. So in this situation, if a patient received response, the median time that it lasts was 9.7 months. These are not numbers that I've seen in small cell before. And it did give us a survival benefit. Earlier I used to quote to all my patients when they progressed on their first line of treatment that you're looking at 6 months or less. Here the median survival for somebody who got talatamab was 15.2 months. This in itself is longer than the survival with first line of treatment. So this is definitely extremely impressive. However, it comes with a cost. The cost here is that when you're artificially trying to connect your soldier cell to your cancer cell, you can initiate a type of response in your body, a side effect known as cytokine release syndrome. Immune cells work by releasing cytokines. These are chemicals they release to kill infection, to kill cancer. But if that release is uncontrolled, it leads to a syndrome called a cytokine release syndrome. It is a potentially life-threatening side effect, which is characterized by this inflammatory response, which could be as simple as a very mild fever, but can really fast progress to hypotension. It can lead to organ failure. And overall incidence with talatamab right now is almost up to 50%, although it is lower grade, means that most patients develop low-grade fever, or maybe they require oxygen, but it's not severe enough to cause organ dysfunction. That's only in a minority of patients. It can also cause a side effect, which is almost like an immune response in your brain, known as ICANS, or immune effector cell-associated neurotoxicity, which is characterized by neurological symptoms. It can start with something as simple as confusion, but then it can rapidly progress to altered mental status, seizures, just swelling in your brain. And overall incidence with tarlatamab here as well is about 8% uh, with the first cycle of treatment. However, this is also lower grade, means that mostly confusion is what we see. However, what is important to know here is tarlatamab, being a revolutionary compound, is just not available everywhere. And the reason for that is that this sort of side effect profile requires a lot of monitoring. It requires early identification. How many times have you called your doctor and said, I'm fatigued, right? And then they say, okay, rest and it'll get better. We don't say that to a tarlatamab patient. If they have fatigue, they come in right away because it can start with fatigue. It can progress rapidly to organ dysfunction. And that's why the first 2 doses of this medication are given in a highly monitored setting in a cancer center. And after it was approved last year on 16th May 2024, we were the first cancer center in the US to offer it to our patients. Until now, we have treated over 40 patients, so we have a pretty good idea of how this is doing overall in a real world population. And I actually submitted an abstract pertaining to this for the ISLAC small cell lung cancer meeting. So, hoping to share the data out with everybody about our first experience. This is a revolutionary drug. However, we still have unmet needs. And where are the unmet needs with tarlatamab? It actually has a longer time to onset for response. I call this a targeted immunotherapy. It's like a super immunotherapy, but immunotherapy is making your immune system work. Anything that makes your immune system work takes some time to work. And here, the median time to onset of response is 1.4 months. Some of my patients don't have 1.4 months. They need a response now. The data that we have is from a very selected population of patients who were on a trial. We need data from patients that we see every day in clinic and a diverse patient group to really assess the risk-benefit ratio of this medication. Right now, it has limited availability and access because of the issues that I mentioned. And here too, even though it attaches to a specific target on small cell, which we know how to measure, we don't use that target to select patients. So we do need to develop markers to predict response to therapy. We need to develop markers to predict people who are going to have bad side effects so we can prevent that from happening. So this is really a big unmet need in small cell lung cancer. However, there is a lot to look forward to, and that's what I'm going to discuss in the future directions of treatment, where the future is really focused on understanding the differences between different small cell lung cancer tumors, how we are using strategies, combination strategies, or new drug strategies to improve existing therapies. And then I'm also going to touch on some of the newer agents that have a lot of hope right now in this area. So I think, Montessa, you mentioned this here, right? Like, why are we not looking like the non-small cell lung cancer curves, right? So what we achieved with immunotherapy were modest benefits. Yes, our curves are like this much apart. We want them to be this much apart, which is what we see in non-small cell lung cancer, which is the curve that is listed here for somebody with EGFR T790M, a particular mutation in non-small cell lung cancer. You can literally fit in a car there if you want. And this is because we are still treating small cell lung cancer as a single disease. There is a lot that is happening to change that. And really, the seminal papers on this came out in 2020, Dr. Rudin, Dr. Oliver, Dr. Poirier's group that really looked at subdividing small cells into different subtypes. And why did it take them so long to do it? Because small cell lung cancer is not simple. It's not as simple as non-small cell, in which you have a single genetic change and that can be targeted. In small cell lung cancer, it is something called transcriptional change, which is a little bit more difficult to capture and a little bit more difficult to follow. But when they did this analysis, they found that they could broadly subdivide small cell lung cancer into these 4 subtypes listed here: ASCL1, NeuroD1, PAU2F3, YAP1. I did a similar study with a database, a genetic database called CARIS, in which I looked at 400 so small cell lung cancer patient samples, and I found that I was able to subdivide small cell lung cancer the same way. Why is this important? Because each of these particular subtypes or these particular states of tumor is associated with vulnerability to a specific type of drug. So it might not be a genetic change, but it's a state of a cancer that if you find that state and you target it, it has a vulnerability. So this was the first time vulnerability was identified in small cell, which could be targeted. However, the big issue with small cell is tissue samples. This is a highly aggressive tumor. We don't have 2 weeks to wait for somebody to give us a biopsy. Sometimes biopsies are just taken with a small needle. We don't have enough to do these more complex transcriptional subtypes, which are different than the genetic subtypes of non-small cell. And that is the reason it has been a little bit more challenging to translate this in the clinic. But there are things which are changing this, and I'm not going to go over the science behind this paper, but it's really, there are groups of scientists that are looking at a simple blood test that could detect a change that could actually help us then detect those states of small cell. And in one of these concepts that I'm intricately involved with through SWOG, we are actually trying to include this as part of our study in small cell lung cancer, this blood collection, so we can actually test it out in real time to see if it's actually predicting those changes in small cell that we really need. Another big achievement in this direction is the PRISM trial, which is looking at it's really the first, I won't say it's the first biomarker small cell trial, but it's really the first seminal trial that's looking at different states of small cell lung cancer at the same time. So the PRISM study is a phase 2 trial, which is looking at adding things to immunotherapy in a selected fashion to see if it improves survival. So every patient who has extensive stage small cell lung cancer is right now treated with chemotherapy plus immunotherapy. And after a few cycles of chemo plus immunotherapy, they are on something called maintenance immunotherapy. That is, we just keep them on immunotherapy for every 3 to 4 weeks till the cancer starts to grow again. And what this study is looking at is capturing the state of small cell lung cancer right at that stage when it has started maintenance therapy, and then checking the state of small cell lung cancer at that time. If it belongs to any of these groups, the therapy is going to be modified. It's going to be personalized to that subtype of small cell lung cancer. And I think this is a beautiful study for many reasons. One reason being that it's actually trying to tackle the problem before it emerges. Once small cell lung cancer starts to grow out from first line therapy, it's very, very hard to do any sort of sophisticated subtyping at that point because we just don't have time. We just need to give something right away. But it's actually trying to capture the cancer at a point where it has been controlled with chemotherapy and not yet progress, and then keep the control for a longer time. So we really, really hope that this helps us move the bar in personalized therapy in small cell lung cancer. We're also trying to improvise on our existing therapies. And I've just listed some trials here that are looking at different strategies, just starting with tarlatamab. They're trying to combine tarlatamab with immunotherapy to further improve survival. They're trying to look at a subcutaneous version of tarlatamab. Maybe that would lead to less of a cytokine response, and maybe that will improve accessibility. We don't know. Lurbinectedin is being looked at the confirmatory trial compared to irinotecan, which is a drug which was used for treatment of small cell that had progressed on first-line treatment in the past. We are also trying to combine lurbinectedin with immunotherapy. And the IM-Forte trial actually has completed accrual. And this is a trial in the maintenance phase that I was talking about, which has actually shown improvement in survival, but we don't have the final results of this published yet. We're also trying to look at other immunotherapy strategies, which I've listed here. We're also trying to look at how to best incorporate radiation therapy to improve outcomes in patients with small cell lung cancer. So definitely a lot happening there. But coming to what's new, what we are looking at for the future, I want to talk about three different concepts that are looking to change the landscape of small cell lung cancer treatment. And I promise you, I'm going to go over each one of them and what they really do. The first one is antibody drug conjugate. Um, life was the treatment of small cell lung cancer was not progressing because we didn't have personalized therapy, but also because we were just dealing with one type of therapy, which was chemotherapy. Now, what has happened over the last few years is we've learned to engineer uh, 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 anti-cancer therapies in a way that it works to bring things that could not be brought together. The problem with chemotherapy is chemotherapy works, but it's given to the entire body. And when it does that, it targets the healthy cells and the cancer cells. So you constantly have to balance the side effects with the effect. The problem with targeted therapy is that, yes, it's only going to target if it is one genetic defect and it blocks that genetic defect. But what do you need if you actually have a target and you need your chemotherapy to go in a targeted fashion and kill the cancer cell and not affect your normal cells? That's where antibody drug conjugates come into picture, in which an antibody, which is again a magnet, attaches to a particular area on the small cell, which it has affinity to. And this magnet is then linked with a linker to a chemotherapy. So now it's going to attack to the cancer cell in a targeted fashion and deliver that chemotherapy in a targeted fashion. Is this perfect? Means that is all the chemotherapy only delivered to the cancer and not to any other cell? No, but it's much, much better than just chemotherapy, which was completely non-specific. And in this area, there are several drugs that are being looked at for small cell lung cancer. And here I've just kind of provided a list of some of these antibody drug conjugates, which are targeting certain highly expressed targets on small cell. I've highlighted two here because I'm going to discuss them a little bit more. The ABBV706 compound targets something called SEZ6 on the surface of small cell. Infinatamab deruxtecan, can never pronounce these words, targets something on the small cell called B7H3. But these are really things that are expressed on small cell. They use it as a magnet and then disperse the chemotherapy in a targeted fashion. This is a figure from the AbbVie study, the earlier version of the AbbVie compound that I had a privilege to participate in my earlier institution, which showed that in patients with small cell lung cancer, whose cancer had progressed on one or more treatments, this drug was effective in a subset of patients. This plot is known as a swimmer plot, which is basically helps us visualize each patient which was enrolled on the study and how they did at different time points in their treatment. And similarly, IDXT, which targets B7H3, very, very early on has shown a response rate of up to 54.8% in patients with small cell lung cancer. Again, very small numbers of patients who were treated, but very exciting response rates for a small cell lung cancer treating physician. Another type of molecule that is really coming up in small cell and neuroendocrine tumors in general is a radiopharmaceutical. Now, what's a radiopharmaceutical? This is all engineering. This is really just combining things in a fashion that helps us deliver things that kill cancer cells to cancer cells and not normal cells. And in this situation, we are using a magnet that gets attracted to a certain part of small cell, and we are linking it not to a chemotherapy, we are linking it to a radioisotope, a radiation delivering compound. And in this way, in a targeted fashion, this compound attaches to small cell and then delivers radiation in a targeted fashion. So this is how it kills small cell. And this is really an area of research and development that's booming. This is not new to cancer treatments. Neuroendocrine tumors have approval for radiopharmaceuticals, and one of the ones which is approved is called PRRT. Um, and while there are studies with PRRT in small cell, the target that they were focusing on is something that was not very highly expressed in small cell. And that's why the newer studies are focusing on DLL3, which is the same target that tarlatamab uses. We know that it's a good target, it's effective. So now we are attaching our radioisotope to the DLL3 rather than SSTR, which was the target which was used by the earlier agents. Another set of compounds that are coming up in this field are the trispecific T cell activating compounds, and this is I call this an improvisation or an attempt to improvisation over tarlatamab. While tarlatamab was binding an immune cell to the small cell, this has a third area. That's why it's trispecific and not bispecific, which is a part of this yellow compound here, yellow area called as anti-albumin domain, which basically just increases its half-life. It just makes our body not destroy it sooner, because all of these are antibodies and our body has an effective way of getting rid of them. This just makes it stick around for a longer time, with the hope that if it sticks around for a longer time, it's going to lead to a better response for a longer time. But studies with this are currently ongoing, and the preliminary results that have been published look extremely promising. So, I always, whenever my patient asks me, like, how am I going to do, I give them numbers, but I also tell them that I don't have a crystal ball. But I guess, we all have a crystal ball in our computer now because ChatGPT knows everything. So I asked ChatGPT, can you predict the future of small cell lung cancer? And it gave me a really high-tech answer in which it looks like our small cell patient is sitting with a lot of options around them, which is very reassuring. But what was more reassuring for me was there was still a doctor present in the picture, and ChatGPT did not try to take my job, because I feel like the big part of my job is the reason I became an oncologist was that I thought that I want to give every information that I know about somebody's cancer to the person who needs to know it the most. And I think that to me is like patient doctor relationship really all about. And I was very happy that ChatGPT still likes that. So in summary, I would like to say that we all know small cell lung cancer is highly aggressive. It grows quickly. It starts in the lung, but quickly spreads to other parts of the bodies. Other type of lung cancer can transform into small cell. So, this is not something that is only restricted to 15% of patients with lung cancer. It's actually much more. It responds quickly to initial therapy, but it comes back. And when it comes back, it is associated with a very limited survival. Recent years have shown new therapies. They have improved small cell lung cancer outcomes, but every treatment that has been approved is associated with limitations. Future directions are definitely personalized therapy. That's what moved the bar in non-small cell. That hopefully is going to move the bar in small cell. And we are seeing this with an improvement in technology to support this effort, which is what made it lag the non-small cell effort. Non-small cell had the technology. It worked. It was feasible. Small cell technology has been a little bit more difficult because it has to capture a state, not a genetic change. There are emerging innovative therapies. We have been able to engineer compounds to work for us. And I think they hold a lot of promise. But I think we should still continue to focus on early detection. Early detection, early detection, early detection. Ask your doctors tell your friends to ask their doctors for CAT scan screening. I'm biased because I'm married to a pulmonologist who also does biopsies for lung cancer for a living. But I cannot tell you how many times he comes to me and says, Sonam, I saw a 5 millimeter nodule and it was small cell lung cancer. And Yes, when it is captured as a 5 millimeter nodule, it is life-saving, right? So we can do that. We can get to these small nodules. We can diagnose small cell lung cancer only if somebody helps us to do that. We also need to continue to focus on study, which work on improving supportive care and tracking quality of life metrics with therapy. This is extremely important. I ask my patients, you know, what is considered acceptable is side effect is what is considered acceptable according to you. So you tell me what is acceptable. You tell me what your goals are. You tell me what is considered acceptable, and we have to learn to monitor and track that and change our treatment accordingly. How can you guys help? I think you've already helped by being here, right? But clinical trials are the key to success in this field, more so in other fields, because I tell my patients, this is not a blood pressure medication. This is not a diabetes medication. These are drugs which are the difference between life and death a lot of times. And the only way we can move this needle forward is by doing good clinical trials. And there has to be science behind them, right? So please ask your doctors when they're offering you clinical trials, why do you think this study drug is going to work for me? Does it have science behind it that's going to work in small cell lung cancer? So, rather than drugs that could work, if somebody says this could work because, they don't have a strong reason behind it, that's probably not a good trial for you. And the good trial for you is the one that has science behind why it's supposed to work in small cell lung cancer. And something that you guys are already doing, supporting research and advocacy. There's so many times that I just feel like lung cancer just does not get the same recognition and support that other cancers do. And every cancer is bad, but this is definitely an area that we need to continue to advocate for. With that, this is my very lovely toddler who is currently being engaged with a movie so that he doesn't scream, which he often tends to do when I'm in a meeting. So,
Are you open to a few questions?
yes,
Good.
absolutely.
So the tartalimab, you talked about the side effects. Now,
Yeah.
what are the criteria before you go on that treatment? Is there any criteria? Because, for instance, when I was on chemotherapy, one time they wouldn't give me the chemo because my blood counts were low, so I had to get a blood transfusion. So before you get that tartalimab, what are is there any underlying criteria that you are eligible beyond, you know, the
Yeah.
second
So
line?
currently, yeah. So currently, the FDA approval is very broad because of how revolutionary this treatment is. So anybody whose cancer has progressed on the first type of treatment for small cell, which is chemotherapy based, can get talatamab. But earlier when we started giving it, it was really a medication that we were trying to offer to all patients because this was something that showed response rates and survivals that we had not seen before. But now that we are learning more about it, since we've treated 40 patients so far, there are a set of patients in which I have observed that the cancer response to the side effect is more than others. They're still working to identify those set of patients. So when some patients come to me and they have a history of a bad side effect with immunotherapy, or they have a pre-existing lung condition that is an inflammatory lung condition, or they already have bad kidneys that are bad for some other reason, a heart that is weak, then I tend to tell them that the risk of those side effects with tarlatamab could be more than the absolute benefit that you would get. And because if you strictly go by clinical trial criteria, you would end up excluding like 70% of our population, I feel, right? But we don't, like, when something gets approved, we make it broader for the entire population. That's what we are doing, but with caution. So, we've already, started deeply studying those patients who had a bad response to treatment, have identified certain risk factors, and at Moffitt, at least, we are giving medications to as a prophylaxis to prevent that. But we are trying to offer it to as many patients as we can, as long as it's safe.
Oh, thank you. And I have a question in the chat. The first quote, they love your child. They said he's adorable. We all,
Thank you.
Um,
Thanks so much.
then the question is, this is all amazing and sounds like there's a lot of hope for a cure. Do any of the new treatments have any effect on small cell lung cancer brain metastasis?
Yes, it's a very, very important question. And the answer to that is we don't know yet, because most of the studies, these are all based on accelerated approvals, means that these were smaller studies that were looking at a really particular group of patients. And most of the times when it's an accelerated approval or it's a smaller study, the one of the exclusion criteria of the study is an active brain met, a brain met that has not been controlled with radiation or treatment before. But this is one of, an area of my research interest. And, since we have treated right now, I think the most patients with tarlatamab in the country, we are trying to look at it within our data set and also expand it with collaborations with other institutions to see if we can give an answer to that. But right now, I think the strategy really is if somebody has an active cancer in the brain that's growing and causing symptoms, that should be controlled first with radiation before getting tarlatamab, just for safety reasons. I think, especially when you're looking at the neurotoxicity with tarlatamab, right? Often symptoms of progressive brain cancer in the brain is same as confusion, altered mental status, all of that. So you always want to make sure that you know what is causing what.
Thank you. I have another question in the chat. Can you speak to any preliminary data on progression-free survival for dotatate?
Yep.
Okay, yep, because that one I did not know in small cell.
Yeah. Yeah, it's still very early on. I think, I actually presented the poster on data for the Raise Bio at ISLAC this last year, and we are still looking at safety. So I think the how effective it is still a question that needs to be addressed. But I think again, it has the science behind it, so I'm hoping that it translates.
Thank you. I'm getting definitely a pronunciation for all these drugs and treatment options. Yes, that one I hadn't heard of. Okay, anyone else?
So my question is I keep hearing screening, but I was 43, so I wasn't eligible for screening. And then I hear that there's not enough people to get into these trials. Yet I've 19 months into this and I'm extensive stage, and I keep getting turned down for trials because I've had too many treatments. So where does somebody like me go? What are my options when screening's not an option? Obviously it's too late, and trials are not an option because I've had too many treatments. So I'm currently looking for a trial. Where does somebody like me go?
This is to how drug development usually works, is when they are this is from experience of me conducting clinical trials, is usually when they are in their very initial stages of development, they have less restrictions on the number of prior lines of treatment. When they move from the phase 1 to phase 2 to phase 3, they get more and more selective on the patient population that can go on the study. So I think that, do I have an option for you at Moffitt right now? I would say no, because we are actually currently working on getting a study like that. But there are studies which are phase 1 studies based on science of working in small cell lung cancer that usually don't have restrictions on previous lines of treatment, as long as you meet the other criteria, which often are how well you're doing, with your everyday activities, how the kidney function has been affected by tumor, or otherwise liver function and all of that. We would love to make studies more accessible. When you'll historically see that, when we write studies, at least like when we do it as part of a cooperative group, we try to make it as broad as possible. But sometimes it becomes more challenging when you're looking at a first-in-human compound, because what happens is you don't know what it's going to do. And what we are taught in medicine overall is first do no harm. And when we don't know if something is actually going to do harm, when we don't even know that basic question, is it going to harm you or not, the selection automatically comes in, is because there's certain things that put you at high risk for side effects. And anything at this point could actually, lead to more problem than good if it causes side effects.
Thank you. I have a question in the chat regarding tarlatamab. Is it only used on extensive stage small cell?
So, so it really depends on how limited stage small cell lung cancer has progressed on treatment. So currently the treatment for limited stage small cell lung cancer is we give the patients a combination of chemotherapy and radiation. And once they complete that, they go on immunotherapy for a year. The hope is that immunotherapy prevents the cancer from coming back for a longer time, but there's still a group of patients in which cancer comes back. So right now, the tarlatamab for limited stage small cell lung cancer is restricted to those patients in whom the cancer has returned after giving this treatment. But there are studies that are actually looking at putting tarlatamab early on. So there are studies that are looking at tarlatamab as a maintenance therapy instead of durvalumab in limited stage small cell lung cancer. So definitely more is coming.
Does anyone else have any more questions? You could raise your hand, wave it, put a feature.
You were talking about tri-specific T cell activating constructs, and was the only one that was listed on there the HPN 328? Was that the only one that was tri, or were the tarlatamab or the?
No, the Harpoon compound was the tri. The tarlatamab is actually a bi because it only targets like CD3 and CD3 and DLL3. So yeah, the only one that has the most data right now is the Harpoon compound.
And that's currently under trial and is recruiting?
Yes.
Okay. Very good.
And it is for both small cell lung cancer and neuroendocrine tumors as well. So small cell is actually is part of a spectrum of tumors called neuroendocrine tumors, and they can be very, very low grade that sometimes don't even require treatment, and very, very high grade, out of which small cell kind of leads the way in being very, very aggressive. But then there is also another type of neuroendocrine tumor that's aggressive, often coexists with small cell, known as large cell neuroendocrine. And these are some of the now the newer studies, now with the understanding that biologically these tumors might be similar, are looking at both the high grade tumors, small cell and large cell neuroendocrine.
Okay, very good. Thank you.
Anyone else? And while you're waiting for any other questions, I do see one. Your thoughts on Temodar used for brain cancer?
Yeah, so Temodar is an option for small cell lung cancer that has gone to the brain because it's actually something that penetrates the blood-brain barrier. But again, the overall times that it is effective is, not a very reliable number. So I've seen it being given sometimes, but often if I actually have an option of radiation, I would choose that more over Temodar.
You had asked earlier about exclusions for like tarlatamab, what would be a pre-existing or something. And I'm actually getting ready to go into one of the BICs on Monday. And I've had to have all kinds of blood tests run outside the normal gamut. So I've been checked for Epstein-Barr, I've been checked for hepatitis, I've been checked for everything, basically everything, but the mono in the past, I forget what that test was called, and it's like each test waiting for that to come in. It's like, okay, did I pass the test?
I know. Yeah.
And it looks like I'm good right now. I had my CT scan, and I should be starting on Monday. But Dr. Puri, I had also been one of the AbbVie trial patients, and I made it through 10 months progression free. And it also, even though the tumor in my lung is showing some growth, it didn't spread anywhere else. So
that's so incredible. I mean, you were one of our patients in that swimmer plots. You were the ones on there, and that's what really gives us hope, because I feel that even 10 months is not something I've heard with standard treatment before. This is this is the way we've been able to engineer compounds to get things together that were not coming together. These are targeted chemotherapies, these are targeted immunotherapies. So really good luck. Being a clinical trial patient, the amount of stress these clinical trials make you go through, make your doctor go through. But really, the eventual aim is to maintain safety. The last thing I ever want to do is give my patient a side effect that then this makes them not qualify for any treatments moving forward. And I think like that's something that we really, really have to watch out for very, very, very carefully.
Absolutely. Thank you so much for your presentation. It's very educational.
I do have a question with the tarlatamab. When you said sometimes the effect is 14.6 months, and we know that small cell grows aggressively, like you said. But is there ever progression that you've seen during that wait time before you see the effect, or does it just maintain stable?
Oh, yes. No. So, this is still very early on, right? So this got FDA approval in May. We've been treating since May. And so May to November is not a lot of months to track every one of our patients who's been on this drug. But there are definitely some patients who are just too sick. And what I've been telling, because we get a lot of referrals from community practices, even academic centers right now, because we're one of the few sites in Florida that's giving the treatment, is that, if the patient's cancer is not controlled, just give something to control it, and then we can evaluate for tarlatamab, because tarlatamab is not going to start working right away. Right. And even by the time you come in, you kind of solve the logistics involved with this treatment that requires you to stay in Tampa for like 48 hours and then come back in a week again and then stay for 48 hours again. Right. There's a lot of logistics involved. Tumor is sticking. So now I've started seeing patients come in when they have already they're getting some sort of a bridging treatment with chemotherapy to at least try to control it. Now, is it going to be effective? We don't know, but at least we are trying to control it with whatever other strategy that we have. And we've seen some patients just don't have those 1.4 months, and unfortunately, they don't do well.
Thank you.
So I was on the tarlatamab trial, and it worked for a year, November to this past November. Very little progression, but I did have to go off because of the progression. And, starting another trial, had a little progression, so I'm going to try another one. But I guess I've been told that I can go back on tarlatamab once I get things under control. And, so that's another thought. And I really didn't have any side effects, except, for the first 24, 48 hours, and loss of taste and of sugar and salt.
Loss of taste is something that's very,
but
very
that's
common.
It. Yeah.
Yeah, because the same receptor is present on your tongue, the DLL3.
But I agree with you that you can't be too sick. You almost have to. I was on it as soon as I finished my first round of chemo and went on immunotherapy. So I ended chemo in August, immunotherapy September, went on tarlatamab in November, in a whole year. A few little progressions, had my adrenal out because it was extensive. But it really kept the cancer at bay. Just little progression, but I wasn't real sick to begin with. So
yeah, you say a wonderful thing, because what kind of cancer does that? This is non-small cell, right? We were used to seeing low progression or slow progression in non-small cell. We were never used to seeing this in small cell. So that's why I feel like even though the benefit might not be in all patients all the time, we are seeing a change. We are seeing a change in the behavior of the tumor by kind of being able to be more effective in recruiting our immune system to take care of it. And this is again exactly what we call as oligoprogression. That's why your doctor is even offering you to go back to tarlatamab. A lot of times what we do after it gets FDA approved is we can just give it to you as standard of care if your insurance approves it. But if you have a trial as an option, which you qualify for, I would rather go for that and then keep tarlatamab in the back pocket if you need it in future, right? So I think that, what we tell the providers who are seeing patients outside of institutions that can give tarlatamab is send the patient early on. Nothing is too early. You get started on first type of treatment for small cell lung cancer. Come see me. Just the fact that you have been seen at a center that can give tarlatamab, you are now their patient. So when the cancer is progressing, all we have to do is just get you back in clinic and get you right into treatment. And if there is any delay, life happens. Just give chemotherapy. Don't wait to get tarlatamab, because then, sometimes the effects are going to be side effects. You're just so sick. And then when you're so sick, it only takes a little bit for you to tip to the wrong direction.
Thank you so much, Dr. Puri. This is amazing. And thank you for giving us your time.
Anytime. I'm always open to questions. I know this is all tough. Anything I can do to relieve the stress, I would be very, very much happy to do that. Thanks so much.
Thank you.
Thank you.